Make the patient comfortable in the supine position with a pillow under the head. Ask the patient to keep the arms at the side or folded across the chest. Stand at the patient's right side and proceed in a systematic fashion with inspection, auscultation, percussion, and palpitation. Inspect the skin for scars, striae, dilated vein, rashes, or ecchymosis. Inspect the symmetry and contour of the abdomen. Is it flat, rounded, protuberant, or scaphoid? Are there any bulges? Then observe the umbilicus. Observe its contour and location and any inflammation, bulges, or hernia. Peristalsis and erotic pulsation are visible in epigastrium. For peristalsis, observe the abdomen for several minutes if you suspect any intestinal obstruction. Normally, peristalsis is visible in thin people. Auscultate the abdomen before performing percussion or palpation because these maneuvers may alter the frequency of bowel sounds. Now place the diaphragm of stethoscope gently on the abdomen. Listen for bowel sounds and note their frequency and character. Normal sound consists of clicks and gurgles occurring at an estimated frequency of 5 to 34 per minute. Occasionally, you may hear the prolonged normal stomach growling. If patient has hypertension, auscultate the epigastrium in each upper quadrant for brood. Auscultate for broods over aorta, iliac arteries, and femoral arteries. Percuss the abdomen to determine the distribution of tympani and dullness. Tympani is a high-pitched musical sound that indicates a hollow space filled by air or gas in the stomach or intestine. Note any dull areas suggesting an underlying mass or enlarged organ. Palpate the four quadrants of the abdomen. Palpate the abdomen with a light gentle dipping motion. Identify any tenderness or increased resistance to your hand. Palpate after asking the patient to exhale, which usually relaxes the abdominal muscle. Again, using the palmar surface of your fingers, press down in all four quadrants. Identify any masses, note their location, size, shape, consistency, tenderness, pulsation, and any mobility with respiration or pressure from the examining hand. Starting at the level well below the umbilicus in the right lower quadrant, percuss upward toward the liver. Identify the lower border of dullness in the mid-clavicular line. Now identify the upper border of liver dullness starting at the nipple line. Percuss downward in the mid-clavicular line until lung resonance shift to liver dullness. Place your left hand behind the patient parallel to and supporting the right 11th and 12th ribs and adjacent soft tissues. Place the right hand on the patient's right abdomen, lateral to the rectus muscle with your fingertips and well below the lower border of liver dullness. Starting palpation too close to the right costal margin risk, missing the lower edge of an enlarged liver that extends into the right lower quadrant. Ask the patient to take a deep breath. Try to feel the liver edge as it slides down to meet your fingertips. Note any tenderness. The normal liver may be slightly tender. Stand to the right of the patient's chest. Place both hands side by side on the right abdomen, below the border of liver dullness. Press in with your fingers and up toward the costal margin. Ask the patient to take a deep breath. Percuss the left and lower anterior chest wall roughly from the border of the cardiac dullness at the sixth rib to the anteriorly axillary line and down to the costal margin, an area termed trabecular space. Note the lateral extent of tympani. Percussion is moderately accurate in detecting splenomegaly. Ask the patient to take a deep breath. Try to feel the tip or edge of the spleen as it comes down to meet your fingertips. Note any tenderness, assess the splenic contour, and measure the distance between the spleen lowest point and the left costal margin. Approximately 5% of normal adults have a palpable spleen tip. Move to the patient left side. Place your right hand behind the patient just below and parallel to the 12th rib, with your fingertips just reaching the costovertebral angle. Lift trying to displace the kidney anteriorly. Place your left hand gently in the left upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply into the left upper quadrant just below the costal margin. Ask the patient to breathe out and then to stop breathing briefly. Slowly release the pressure on your left hand, feeling at the same time for the kidney to slide back into its expiratory position. If the kidney is palpable, assess its size, contour, and any tenderness. Now to examine patient's right kidney, return to patient right side. Ask the patient to take a deep breath. A normal right kidney may be palpable, especially when the patient is thin and the abdominal muscles are relaxed. Use your left hand to lift up from the back and your right hand to feel deep in the right upper quadrant. The kidney may be slightly tender. If the kidneys are tender to palpation, assess percussion tenderness over the costovertebral angle. Place the ball of one hand in the costovertebral angle and strike it with ulnar surface of your fist. Use enough force to cause a perceptible but painless jar or thud. To assess the aorta, press the upper abdomen slightly left of midline and feel for the aorta's pulsation. Now try to assess the width of the aorta, especially in older smokers at risk for abdominal aortic aneurysm. Pressing gently with a hand on each side of the aorta, try to estimate its width. Normally it should be less than 3 cm.